It's really great to be here. I've been incredibly impressed by what's here in Colorado, what you've done together, the resources that are pulling together, and the things that you're going to be able to do going forward. I'm here to get us, as a community of people interested in healthcare and democracy, to try to stop admiring the problem. And I want to start by saying, I want to give you a little more background about myself and sort of where I come from and why I think the problem is there. I'm the grandchild of immigrants. All four of my grandparents came from the same small area of Russia, Poland. I had a great uncle who was undocumented. My grandfather, in 1925, got an early Model T and drove to Canada to pick him up and bring him across the border. And coming from that immigrant community, I was taught a single critical ethical principle, which is that it is inappropriate and immoral to profit from anyone else's misfortune. Now, I brought that principle into community organizing and into medicine, and found myself in 1986 as a National Health Service Corps scholar placed in the fifth poorest county in the United States in Hancock County, Tennessee. Now, Hancock County, Tennessee was a county of 6,000 people. It had two physicians who were internship trained but not residency trained. And they together leased the county hospital, the 20-bed county hospital, from the county for $1 a year. The county hospital had no laboratory. It had no operating room, and yet it did maternity care. The approach to a difficulty, or any difficulty of that somebody was having in labor, was to call the helicopter and wait till the helicopter showed up. So we had one of the highest maternal mortality rates in the nation, and one of the highest infant mortality rates, to the extent we could actually measure it because the denominator was too small. Everyone who came to the emergency room was seen only by a licensed practical nurse because everybody went home at 5 o'clock. And everyone who came to the emergency room got a shot of lincomycin, Kenalog, and Benadryl, which probably really was able to cure almost anything that ailed people, at least in the short run. And then they'd get admitted to the hospital, and they'd spend a certain amount of time in the hospital to be determined by the physicians, until the physicians understood that their resources had run out, and then they were discharged home. But because nobody had health insurance, they couldn't pay the bill, and so they'd get taken to court, and they would lose the land that they had inherited from their forebears. And so this was a county of 6,000 people in which most of the population was poor, that was 66% illiterate, and in which there were two physicians who each owned 7,000 acres and had herds of purebred cattle. And had some of the worst population health outcomes imaginable. That was my look at what healthcare could do to a community. And that's what I brought to the rest of my practice. And that's what I'm concerned about when I look at the United States. So it's time we owned that healthcare in the United States is an expensive failure. 37% of the population is immunized against influenza, only 37%. In 2017-18, we had 80,000 influenza-associated deaths. Barely half of us get needed colon cancer screening for an entirely preventable disease. We have 50,000 preventable deaths in the United States. We have 30 to 40,000 completely preventable new HIV infections each year. Remember that we discovered highly active retroviral therapy in 1996, and CDC recommended universal screening starting in 2003, and yet there are 150,000 Americans who who are infected with HIV and don't know it. There are 20,000 mostly preventable deaths from hepatitis C. We have 250,000 deaths a year from medical error, and about 800,000 mostly preventable deaths each year from diabetes, stroke, and heart disease. My friends who are preventive cardiologists believe that 80% of these deaths are preventable, and we are failing to do it. Most advanced countries have far better outcomes and lower costs. Their costs are 50% less on average, but actually the countries with the best outcome, their costs are 60% less. Their outcomes are way better than ours. Their infant mortality rates are a third of ours on average, but the infant mortality rate in the United States is 9 times the best achievable the best achievable rates for African Americans. Their life expectancy is 4 years longer, and our life expectancy is failing. We now rank 64th in the world, despite spending on average twice as much as the rest of the others, and we have these huge health disparities with life expectancies neighborhood by neighborhood that can vary by 20 or 25 years, just a stop or two away on a metro or on a subway, and these huge disparities in infant mortality that are unacceptable. Healthcare in the United States now cost $3.65 trillion in 2018. It will probably cost close to $4 trillion this year, more than twice what other countries spend. And of that spend, $1.2 to $1.8 trillion a year is wasted or unnecessary, and most of it comes out as profit for someone else. Now, $1 to $1.2 to $1.5 trillion sounds like an awful lot of money to me, but if you want to conceptualize it, does anybody know what the total student loan indebtedness in the United States is? It's $1.5 trillion. We waste enough in a single year to send every graduating senior to the best college in America. And that, to a certain extent, is on us. Healthcare cost is cannibalizing the rest of our social services. This is just Massachusetts, but we could do pretty much the same thing for any state as healthcare cost has gone up. Spending on mental health, on public health, on education, on human services, on housing, on public safety, on local aid, and on public transportation has shrunk and is disappearing. I go to a town meeting each year, a financial town meeting in the little town of Situate where I live, and each year we basically say the same thing. We got to cut some service, the late buses one year, the band program another year, because we couldn't afford them anymore. At the same time, the cost of health insurance for town employees was going up 3 to 5 to 9% a year. And so we are cross-subsidizing the disappearance of our services by supporting medical care that probably doesn't matter much. And all this money actually is a direct threat to democracy. 0.03% of $1.5 trillion is used for lobbying, which 0.03% doesn't sound like much till you run the numbers. That's $500 million a year. I spent 4 years in state government, and I have never met a legislator who could stand up to that kind of lobbying attention. And so what happens is our legislatures and our Congress doesn't do what is in the best interest of their constituents. They do what's in the best interest of the lobbying. So you will recall during the Affordable Care Act, we didn't get a public option, and we didn't get the ability to negotiate drug prices under Medicare. Those are things that would have created huge cost savings, but the reason we didn't get them was because the insurance industry or the pharmaceutical industry used its lobbying might to stop those things, and stop those things effectively, though most people think it was in the interest of all Americans. Most advanced countries have a Ministry of Health, which organizes services, measures outcome, and oversees funding. We, on the other hand, have alphabet soup. CMS, CDC, HRSA, SAMHSA, you name it. And let me tell you, they don't talk to each other. What I heard was that Colorado did great things with the SIM money. But one of my most frightening mornings happened in Washington in 2015 when I went with the Lieutenant Governor of Rhode Island to a meeting in Washington about the state innovation models. And our colleagues in federal government were going to give away $3 billion, a little bit to each state, a little bit in terms of millions. And we were there to learn how to get that money. And I heard the leadership of all these august organizations stand on the podium and say pretty much the following thing. Gee whiz, we haven't figured out how to spend money effectively so that our spending on health creates better health outcomes. So can you please use this money to show us how? If they were asking us, and they're in charge of the federal bureaucracy, let me tell you, we are in trouble. To make it worse, in many ways, public health is impotent. We have no real data. We have birth certificate data and death certificate data. I suspect many of you in the room have filled out death certificates at 3 o'clock in the morning and understand how accurate those death certificates really are. We have some survey data that tells us about the incidence and prevalence of disease, but we don't know anything about what's happening in communities, about the incidence and prevalence of disease in communities, and we don't have a way to reach the people who are affected by those diseases and conditions because we have no data. There is also no public consensus about the value of intelligent regulation except in a few large cities and some enlightened states, of which I'm sorry to report Rhode Island is not included. During my time in state government, I had the opportunity to talk to Kevin Concannon, who was a Deputy Secretary of USDA, the folks who control SNAP or food stamps. Rhode Island is an entirely red state. We have two political parties. We have Democrats and dissident Democrats. And so I got to say to Kevin, gee whiz, we are the place to restrict SNAP benefits so that they can't be used for potato chips and soda. And I'm pretty sure I could get the support of the Rhode Island legislature for doing that, and I'm certain I could get the support of the governor. And Kevin said, and Kevin, who's from Maine and is a really good guy, said, gee whiz, I would love to do that with you. I think that's great. Only to try that would be the end of my career and the end of the career of anybody associated with it, because there is no public consensus around it. And as you begin to think about other opportunities for widespread public health interventions, the consensus to do that just doesn't work. There are places, I understand there's a fairly strong anti-vaccine movement here, so don't tell them I'm here. Rhode Island became the first state in the nation to require HPV vaccination, and boy, we got it by the skin of our teeth, and I think it would be almost impossible to do it in any other place. The governor of Texas tried to do it, and he rescinded it in about 2 weeks. And finally, from a public health perspective, we have no boots on the ground. We have the ability to chase down outbreaks. We have the ability to put up bulletin boards, and sometimes, if we can afford it, to put up television advertising. But we don't have the ability to find every smoker and help every smoker stop smoking. We don't have the ability to test every American adult who's 13 to 64 for HIV, find everybody who's positive, get them in treatment and maintain them in treatment, which is all it would take to stop the HIV epidemic tomorrow. We just don't have any boots on the ground, except perhaps the people in this room, our primary care colleagues, who are our boots on the ground, if we could all ever learn to talk to each other. Now the solution, if you look around the world, is to provide primary care to all Americans. It's there, we've got mountains of evidence in favor of it. It's what everybody else does except us. Most advanced countries provide primary care to everyone: Finland, Denmark, Israel, Cuba, Spain, the United Kingdom. Finland, when I went to write this book, I decided I'd go about it by looking up the countries with the best public health outcomes and the lowest costs, and see what they did that we don't do. And then when I looked up those countries, there were 4 or 5, and one was Finland, which has one of the longest life expectancies in the world. And I thought, gee, that's interesting. There was a little light bulb that went off in the back of my brain. I was in residency in the 80s when the first papers came out showing the effectiveness of cholesterol-lowering medicine on cardiovascular mortality and morbidity. And what I remembered distantly was that most of those papers, published in the New England Journal and other places, their lead authors had funny-sounding names, funny-sounding to me anyway. And that was because most of them were Finnish. And that was because Finland had the highest heart disease mortality in the world in the 80s because of some lifestyle choices made by people in a Finnish province called North Karelia, where farmers started, filled their sausages with pork fat and stopped exercising, did a bunch of other things that really set them up to have significant coronary vascular disease when people were in their 40s and 50s. So what the Finns did was they did 2 things. First of all, they started doing some guerrilla marketing around exercise and diet. They went into the bar rooms and got the guys on the bar rooms to go cross-country skiing, to start mountain biking. And they talked to the farmers and got them to replace the pork fat with mushrooms, and they subsidized a bunch of that. And that helped some. And then they went around the country and they opened up 1 primary care center for every 10,000 people, and made sure that everybody had a primary care center to go to, and made sure that every community had a primary care center, and made sure that primary care center was taking responsibility, not just for the individual people, but for the health outcomes of their own community. And by 2017 or 18, Finland had become one of the healthiest countries in the world. And by the way, their per person per year cost of health care is about $4,500. Anybody know what ours is as a nation on average? It's about $11,000. I just checked on Colorado's. You do better than most of the rest of us. But you are adjusted for inflation as, in my back of the envelope calculation, probably about $10,000 per person per year. The Finns, $4,500, better outcomes by far. Their infant mortality rate is 1/3 of what ours is. Spain converted to a population-based system in the 1980s, and they are now the best rated healthcare system in the world. Most advanced countries not only provide primary care to everyone, they spend 3 times what we spend on primary care as a percentage of our total primary care spend. Half or more of their clinicians are primary care doctors. They provide primary care to everyone in every neighborhood and every community. Compare that to what we do, which is not much. In the US, on the other hand, primary care reaches fewer and fewer Americans. I got some insurance company executives to run some data for me and looked at what percent of their insureds had had a preventive exam or hadn't had a preventive exam in the last 2 years, something like 45 to 48%, but that includes kids who have much more frequent preventive exams. So everybody's best guess is the number is more like 30% of us in the United States, 30, 35%, have a regular primary care connection that is meaningful. That means, where prevention happens. Now, among millennials, 45% can't even identify a primary care clinician at all. And this is not to blame millennials for this too. This is because we haven't articulated a primary care delivery system in every community that can serve all Americans and all millennials in a way millennials want to be connected. We keep doing it the way we've always done it. There are too many places where you call a clinician's office and get told, well, if you're sick today, you can come in 2 weeks. Or, you can have an appointment at, 3:30 when you have to pick up your kid. We haven't figured out a way to be open to everybody in the way they want us to approach them. Now, what would primary care for all Americans look like? It will look, I think, a little bit like what we're doing in Central Falls, Rhode Island, where we've built a single clinical enterprise that is responsible for taking care of the entire city of 20,000 people. Clinicians, mental behavioral health people, EMTs, substance use disorder counselors, housing people. Everybody is in this stew together, working together not just to take care of the people who walk through our door, but to take care of the entire population of the city, whether they walk through our door or not. That's what we've never done in the United States, but that's what we need to do. This is the tiny little state of Rhode Island with one community health center, what we call neighborhood health station, for every 10,000 people. That's what the state would look like. And basically what it says is every mile or two, there would be a place that's open from 8 o'clock in the morning till 8 o'clock at night and open on weekends with urgent care connected to primary care, and with each contact leveraged as opportunities for prevention. Building relationships that matter over time with the team of clinicians and other health workers, community health workers, and health coaches best suited to take care of that population as a whole. And it means that every person in the United States has to have a primary care medical home. That's what our colleagues in the UK do. We don't even come close to it. But actually, the what to do is reasonably easy. If you look around the world, what to do is pretty straightforward. You get primary care to all Americans. It's the how that's the challenge. You don't change a $3.6 trillion industry by asking it to change. You change it by building a national movement to change it. And that's what I am here to talk to you about today. And that's what I'm here to ask you and to challenge you to do, so we get this done together. Now, you might think this is impossible, but I want to talk about two people who have been role models for me. Bernie Lown is 97 years old and lives in Chestnut Hill, Massachusetts. He is a world-renowned cardiologist. He was the inventor of the defibrillator. He designed modern CCU care. He was the guy who figured out that if you take people who have had a heart attack and put them in bed for 2 weeks, you will get them to have pulmonary emboli and die. So he got people up and moving around for the first time. He described the Lown-Levine-Ganong syndrome, the second pre-excitation syndrome, the second in frequency after Wolff Parkinson White. He was a founder of Physicians for Social Responsibility. And then when he got to his 60s, that was in the 70s, we were in the middle of an arms race. And he realized that if that arms race continued and we blew the place up, all his cardiology was going to be for nothing. So he called up a colleague in the Soviet Union, Dr. Yevgeny Chasnov, and they enlisted the support of, get this, 400,000 other physicians from around the globe. They published papers in all journals. They gave talks. They organized communities. And they actually forced the nuclear disarmament of the late 70s and early 80s. And for that, he got the Nobel Peace Prize in 1985. So, you know, if he can do it, well, we ought to think about what we can do. And then, many of us know about Jack Geiger, who was a founder of Physicians for Social Responsibility, a founder of Physicians for Human Rights, a founder of the Medical Committee for Human Rights, and basically single-handedly was the founder of the Community Health Center movement in the United States. He brought ideas from South Africa to the United States, went to the OEO and the Office of Economic Opportunity and said, can you give me $10,000? And they said, nope, but how can you do this with $1 million? Opened up 2 sites, one in Columbia Point outside of Boston, one in Mount Bayou, Mississippi, and that movement has grown to 14, I'm sorry? Sure.
Do you know where the third site that was opened in the country was?
I do not.
Eastside Neighborhood Health Center in Denver, Colorado.
You see? So you're part of this history, not a surprise. 1,400 health centers, now 9,000 sites, taking care of 27 million Americans. Health centers in Rhode Island take care of 20% of the entire population with the best measured primary care in the nation. And when you look backward, it's pretty clear that democracy in the United States has been continuously reinvented by our social movements, starting with the American Revolution itself, through the abolitionist movement and the movement for women's suffrage, through the labor union movement and the anti-war movement and the civil rights movement and the movement for marriage equality. We have reinvented ourselves over and over again and recreated democracy many times over by working together, standing up together, and changing things. And if we can do it for those things, then we ought to be able to build the movement for health care in the United States. Now, to do that, we need to learn some community organizing skills. Community organizing isn't highly difficult. It just is a skill like any other skill. It starts meeting people where they are as they are. I actually think exam rooms are ideal. Our job becomes finding and refining a motivating issue, finding something that resonates with the people that you're talking to. For some, it's healthcare cost. For some, it's providing healthcare to everyone. For some, it's about how healthcare is limiting our freedom. And for some, it's about healthcare for people, not for profiteers. And then you bring a few people together, always feed them. Thank you for lunch. Pick a small winnable battle, win it, and then have a really big party. Those of you who are community organizers in the room, is that a reasonable representation? Valuable to build regional coalitions, create a statewide legislative strategy, and work very hard to open the political space for change. Because any of you who have worked with the legislature probably understand that just having a good idea isn't enough. Making sure that there is enough support at the community level so that there is the political space for legislators to do what they need to do. Politics is the art of the possible, not the probable. And our job becomes making that possible probable by getting people involved. In order to build this movement, we all need to pitch in, starting in exam rooms, starting to talk about cost, about the cost of insulin or of EpiPen, or of all the medicines that used to be generic and suddenly disappeared or are now unaffordable. We'll need to talk about freedom, asking people whether they can change jobs anytime they want or whether they now have to worry about their health insurance. About talking to people about when your doctor wants to change jobs, whether you can follow her, or whether your doctor is actually free to say what she wants, or is what she says governed by a contract she's basically forced to sign. We need to be talking about profit and knowing these numbers. United Healthcare and CVS are now $100 billion a year corporations. Larry Merlo, who's the CEO of CVS, now makes $12 million a year before bonuses and stock options. And most of us need to know what the CEOs and 5 highest earners of our nonprofit healthcare corporations actually make. In too many places, it's not $300,000 a year or $500,000 a year. It's $3 million or $10 million or $12 million or $17 million in nonprofit corporations. And this is all easily discoverable just by doing a little homework. We need to talk about wage theft. The average American sees about $5,000 of income disappear into someone else's healthcare profit. And we need to talk about fairness. Rich Americans live longer than most of us, sometimes 25 years longer. And remember that African American kids in the United States and in Colorado just as well are 3 times as likely to die in infancy as white kids. And finally, we need to talk about democracy, about how all this money is destroying the democracy we hold so dear. when the healthcare CEO calls the governor or the Speaker of the House, the governor or the Speaker of the House always takes their call. When you call, does the governor or speaker take your call? And if not, what explains the difference? Now, the people in this room are in many ways the most important people there are. You are the community's experts. We have the opportunity to learn these facts, to start speaking in living rooms, in libraries, in churches, mosques, social clubs, synagogues, to go to what in Rhode Island we call the opening of an envelope, wherever there are people gathered together to show up. And it's also possible and helpful to begin to bring a small group of people together to meet once a month to figure out how to approach what we need to do each in our own communities. There are opportunities to develop a multidisciplinary team for your own community, a whole group of people working together to figure out how to help with the health care and the social challenges of people in the community at greatest risk and with greatest need. We have the opportunity to lead by example, for all of us to move our personal health care to a community health center, to help community members get on health center boards and on hospital boards, to actually get involved with health center and hospital governance, and to build partnerships with other community organizations so people learn to trust each other and work together and can imagine what it would be like to run a healthcare system that takes care of everyone together, which is what we must do. There are opportunities to bring healthcare workers together in your own community so we get to know each other and trust each other. One of the things that I failed to do was understand there were many different kinds of healthcare professionals who are going to be in the room today, and I'm thrilled that everyone's here. There isn't enough comment in what I'm about to say about nursing and about some other kinds of professionals, but we are all in this together. We need to learn to trust each other, work together, and build a healthcare system together. From time to time, we need to take action to improve patient care. This is a bunch of people working on the insulin cost issue from the Lown Institute. We need to build statewide coalitions, bringing everyone who's involved together to create a big tent approach to primary care and a healthcare system. Folks who are in business are our allies. They suffer from these costs. And mayors and city councils are allies. They struggle with the poor health outcomes that our healthcare mess has created. There are opportunities to build statewide coalitions, to change things, to pass the primary care spend legislation that you've all been working on. There are probably ways of beginning to capitate Colorado Medicaid and capitate it just for primary care and do it fairly. So there's a secure funds flow and that gives practices and community health centers the wherewithal they need to practice prevention and bring prevention to everyone and to make sure everyone have access. There are reasons, I think, to make direct primary care payments count toward insurance deductibles, which will help our colleagues doing direct primary care to do it better and more securely. I think states should be working on developing a primary care trust, a single payer for primary care. And you can't do that in all states. You can do that in red states, and blue states, not in red states. But it's something that I think we need to look at as a pathway to provide primary care to everyone. I think states ought to be making hospital boards elected positions because too many boards just appoint each other. I think there are opportunities to give the Colorado Department of Health sign-off authority over the community benefit programs so that hospitals and other healthcare institutions align their work and focus on providing the best outcomes for entire communities and do it at the lowest cost. Remember, you are big tent primary care and you are the change agents for Colorado. I think many of us need to tithe. This is an idea I stole from our colleague Kurt Stange in Cleveland. We need to put some of our, I don't want to say ill-gotten gains, but some of the money we've been able to make, we do better financially than many of our colleagues. And we need to put some of that money back into the organizing process so that organizers can help us pull communities together to do this work. Now, when I gave this talk a couple of weeks ago at Unity Healthcare, a couple of residents looked at me and said, it's overwhelming. And in a certain way, it may feel overwhelming. So I tried to break it down a little bit and think about what different people can do. Because none of us can do it all, and none of us can do it all at once. So for medical students, that means getting their own care from a community health center, learning the data about Colorado and Denver in the US, talking to patients in exam rooms about cost, fairness, and democracy, and learning from each other, trying to join organizations that might be helpful because their numbers help those organizations be more effective advocates. Residents can help develop the data so that everyone has that data at their fingertips. They can organize weekly healthcare hangouts, write letters, go and testify, and also get their care from a community health center and talk to patients in exam rooms. And attendings can know and use the data at every opportunity. Every time you get together for dinner or for lunch with friends, I can be a little boring at a party, but we all need to be just a little boring at a party because in fact, our friends and colleagues look to us for information and leadership, and we need to have that at our fingertips. I think people in practice can organize monthly discussion groups for their neighborhood, to begin to tithe a little bit, and to begin to accept that we can do this together, to encourage medical students and residents, and to remember to never, ever give up. Sometimes it gets discouraging. So sometimes in the middle of the night, I wonder whether we really can do this, whether this is a doable thing. And building a movement is not anything I ever signed up to do or really want to do. There are other things I am equally attracted by, to say the least. But then I think about my kids and the grandchildren I hope they will eventually create, and think about what I got and what I'm going to pass on. And it makes me wonder whether I can be proud of what we've done together. I know I can't accept what healthcare has done or what the healthcare market has done to our profession, our patients, or to democracy itself. These poor health outcomes, rising inequality, and actually funding the polarization of this nation. So, do I think we can do it? Yes, I think we can. This, in many ways, is our Normandy. The generation that came before me stood up and fought to defend democracy. They fought and died for it. And they served this nation well. I think this healthcare mess is our Normandy. And if what we have now is the opportunity to distinguish ourselves and take what we've gotten and pass it on so that the people who come after us have something to be proud of and something to sustain them. In the words of the famous organizer Saul Alinsky, either we better find a way or we better make one, but there's no better group of people in the United States to make that happen than the group of people in this room. Thank you.